Hello, and thank you for joining this HCP Live TV Peer Exchange. This program features expert panel discussions with a focus on current and emerging therapies for the treatment of multiple sclerosis. In particular, we'll be highlighting the risks and benefits of disease-modifying therapies, the factors involved in switching therapies, and the impact that the new oral treatment options may have on clinical decision-making. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University and an associate director of surgical intensive care at the New York Presbyterian Hospital in New York. Participating today on our distinguished panel are Patricia K. Coyle, MD, professor and vice chair, Department of Neurology, Stony Brook University Medical Center in Stony Brook, New York. Andrew D. Goodman, MD, FAAN, professor of neurology, director, Multiple Sclerosis Center, Department of Neurology at the University of Rochester Medical Center in Rochester, New York. Stephen Krieger, MD, assistant professor of neurology, Corinne Goldsmith Dickinson Center for MS, and director, neurology residency program at the Icahn School of Medicine at Mount Sinai. Clyde E. Markowitz, MD, director of the MS Center and associate professor of neurology at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia. Thanks again for joining us. So why don't we get started? We have a whole list of medications that we can talk about, and some of them have different mechanisms of action. This is almost a brave new world, isn't it, of MS medications. Clyde, why don't you start us off? There are injectable agents, infused agents, oral agents. Where do all these things fall out?
So if you really look back over the last maybe 15 or so years, we started out with our first therapies back in the early 90s. They were injectable therapies. And over the years, we've had a few different injectable therapies, some that were interferon-based, some that were gluteamine acetate. And then eventually it became obvious that we needed non-injectable drugs. And so there have been efforts to look at getting orals to market. We now have 3 oral agents.
But there were, in the middle there were infused agents too, right?
Correct. Actually, there's at least 2 agents that came to market that were infusible. One that was used a little bit more for a progressive, very active population of MS patients, and then another one that came around mid-2000s that looked very promising, but ended up having some complication issues, and then it got put back on the market, and it's currently used and has some great benefits.
So these are what? These were botoxantrone and natalizumab?
Correct. Natalizumab.
I even pronounced that right.
Yeah.
How about that?
So the natalizumab is actually regaining a lot of interest because we now have abilities to screen patients for concerns of PML or progressive multifocal leukoencephalopathy.
And I want to get into that a little bit later on. But all of those require a needle so far.
So
and then we have the oral agents.
We have 3 oral drugs that have now been approved. And there's additional ones that are in clinical development at this point. But when you look at what the drugs have been able to do, they've been able to show benefits with regards to reducing the attack rate, frequency of clinical attacks. They reduce new lesion formation on MRI. They slow progression of the disability that patients with MS will experience. And if you really look, it has even reduced the requirements for certain corticosteroid treatments or things that would require people to go to the hospital and get administered. So reducing the attack rates have actually reduced that as well.
And to make it clear, the oral agents that we're talking about are what? There's teriflunomide, there's fingolimod, and dimethyl fumarate.
Correct.
And we're going to parse these out going on.
Absolutely.
As well. And as I say in almost every one of these broadcasts, whoever makes up these names needs a sharp talking to. Impossible. But the availability of these drugs really seems, if I understand you correctly, to have changed the need for relapse treatments. Is that fair?
I think that's fairly accurate. All the trials have really looked at the need for corticosteroid treatments during the clinical trials, and it's been a significant reduction in the requirement for having people get administered, for hospitalizations or even just getting steroids in general for attacks.
Now, I must